Unit 5, Cardiac Disorders. These are our objectives. Now let's review the electrical pathway of the heart. So basically, your cardiac pacemakers. So this is your SA node, AV bundle or bundle of His. Then you have the left and right bundle branches, and you have the Purkinje fibers. Know that your heart's primary pacemaker is the SA node. So the SA node typically beats at 60 to 100 beats per minute. The AV node, on the other hand, beats about 40 to 60 per minute, and the Purkinje would beat 20 to 40 per minute. And again, like I said earlier, the primary pacemaker for your heart is the SA node. Cardiac cycle, when we talk about depolarization, we're talking about systole or the contraction of the heart. On the other hand, repolarization is diastole or resting of the heart or the relaxation. When we start talking about the different disease processes, before we can actually understand those disease processes, it is very important to understand the cardiac blood flow. So please remember this, memorize this, and make sure to highlight it in your notes or outlines. This is an illustration of the cardiac blood flow. So typically, it will start in the superior and inferior vena cava, then it will go to the right atrium, through the tricuspid valve, and then to the right ventricle. Then it will go to the pulmonary valve, pulmonary arteries, and then pulmonary veins, then goes back to the left atrium, and then mitral valve or bicuspid valve, and the left ventricle. Every semester, you're going to be learning about the different heart rhythms, and you're going to be learning about the different cardiac dysrhythmias or arrhythmias. So there are common causes of dysrhythmia. So generally speaking, causes of dysrhythmias include enhanced automaticity, irritable focus, escape beats rhythm, and conduction disturbances. More specific causes of dysrhythmia, so catecholamines, medications, use of illicit drugs, digitalis toxicity or digoxin toxicity, acidosis or alkalosis, so regardless, right, any pH abnormality can lead to dysrhythmias, hypoxemia can cause dysrhythmias, myocardial ischemia or myocardial infarction, and electrolyte imbalances such as hypokalemia, hypocalcemia, and one thing that I didn't include here is hypomagnesemia can also lead to dysrhythmias. And then in addition to hypokalemia, hyperkalemia can also lead to cardiac dysrhythmias. There are several reasons why we would want to put a patient on ECG or EKG monitoring or electrocardiogram monitoring. So if a patient has a known cardiac history, they are likely to develop some sort of arrhythmia. So it's very important to continuously monitor them, especially when they're admitted for some acute reasons. Critical care patients, right, they're very sick, so they're very unstable. Therefore, we need to continuously monitor them. Post-cardiac arrest, now the heart is already irritated to begin with. Those are the people that you also want to continuously monitor. Patients with acute coronary syndrome. Also, you have post-cardiac surgery patients or post-PCI or percutaneous intervention. Also, patients who are, for one reason or another, they are already at an increased risk for dysrhythmias. And maybe they already have a dysrhythmia, or they have an implantable device such as an AICD or a cardiac pacemaker. Also, if they're on any medication that can cause QT prolongation or induce long QT, then they need to be on the monitor. So it is also important to know the drugs that we're giving our patients and the potential effects to a patient's heart rhythm. So if it is known to prolong QT, before we can even give it, we need to make sure that they're on a cardiac monitor. In addition, patients with heart failure, pulmonary edema, and then if somebody is under conscious sedation. There are many other indications for EKG monitoring, but these are some of the common reasons why we need to monitor our patients continuously on an EKG. For your EKG, they can be 12-lead, ambulatory, they're just for monitoring purposes, or they can be on telemetry. This is basically your 5-lead EKG. So if you have a 5-lead EKG, you need to learn how to place them. So you need to know where to place each electrode. So we call it lead, but it's really electrodes. The 5-lead EKG, it has white, black, brown, green, and red leads or electrodes. Something to remember when it comes to remembering the placement of EKG would be white over right, smoke over fire, clouds over grass, chocolate over your heart. And then sometimes I like to think about it as black. It has the L, right? So then I put it to the left arm. And then white sounds like right. So it goes to the right arm. and then chocolate for your heart, grass under the clouds, and then red would be under the black lead or electrode, which is basically smoke over fire. So the white electrode will be near the right midclavicular, directly below the clavicle. So this would be the position for that. And then the black electrode, it's going to be in the near left midclavicular, directly below the clavicle. And then the brown placement would be in the right of the sternum, so slightly right. So this is your sternum, slightly right at the 4th intercostal space. And then the green one will be between the 6th and 7th intercostal space on the right midclavicular line. And then the red would be between the 6th and 7th intercostal space on the left midclavicular line. So when we're talking about midclavicular line, it's really like if you look at the clavicle, right? Like at the middle of the clavicle. And if you want to draw a straight line, that's going to be where it's going to be located. Know your landmarks. Now you have the real definition of the lead. So leads are basically views. So they take a picture of the heart. So depending on what lead we're looking at, right, it's going to be a certain side of the heart that we're looking at. So you have lead 1, 2, and 3. In order to interpret your EKG rhythms, you have to really get used to looking at the EKG paper. So when it is basically is full of boxes. So the vertical lines are basically the voltage, and then the horizontal lines are for the time. So like we talked about earlier, right? So the vertical stands for the voltage, and then the horizontal would be time. So each box, this box right here, is basically 0.2 seconds. So for 3 seconds, there are 15 boxes. For 6 seconds, there are 30 boxes. So again, the EKG tracings are recorded on a grid paper. The horizontal axis of the EKG paper records time with black marks at the top indicating the 3-second interval, while each second is marked by the 5 large grid blocks. Each large block equals to 0.2 seconds that I showed you earlier. And then the vertical axis records EKG amplitude or voltage. So 2 large blocks equal to 1 millivolt. And each small block equals to 0.1 millivolt. And when within the large blocks are 5 small blocks, each representing 0.04 seconds. So this is another illustration just to make it easier to look at the boxes and their measurement. So again, the small, so this is just amplified or magnified. So each small box is 0.04 seconds. And then a large one, right, 5 of them, which consist of a large box, would be 0.2 seconds. So 5 of this, right, 5 of these large boxes equals to 1 second, 15 large boxes equals to 3 seconds, and 30 boxes equals to 6 seconds. So that's basically where we get our 6-second strip. Let's talk about the different waveforms. So in order to measure EKGs, you actually have to measure the different waveforms. But in order to do that, you have to know where they start and where they end. First, we're going to talk about the PRI or PR interval. So the PR interval is this right here. It starts at the beginning of the P wave. So this is the P wave, beginning of the P wave, and beginning of QRS. So this represents the atrial depolarization, or basically atrial contraction. When we say interval consists of a segment and a waveform. As you can see here, this is a waveform and this is a segment. So a segment is a line. Now next is the QRS complex. So the QRS complex, which is this one right here, QRS complex begins with the Q wave and ends with the S wave. It represents the depolarization of the ventricles. Complex, when we say complex on a waveform, it means that it consists of multiple waveforms. So in this case, right, there's the Q, there's the R, and there's the S. So the waveforms basically form a V. Now, ST segment, the measurement starts in the end of the S wave, where the S wave ends, until the beginning of the T wave. So segment, as I mentioned earlier, is a line. Now, when it comes to the QT interval or QTI, we measure from the beginning of the Q wave until the end of the T wave. We also need to identify the isoelectric line. So this is going to be very important later on once we start determining if basically the ST segment is isoelectric or not. The isoelectric line is really the line where the PRI is at, so the interval over here. So if we draw a straight line, that's going to be the isoelectric line. So the line over here. Alright, so I know these waveforms look very intimidating, but these are actually called artifacts. So artifacts are a result of movements. They're actually not dysrhythmias. They're from movements, maybe from shaking if your patient is shivering or has seizures, or maybe the electrodes are loose, so it's not picking it up correctly. It will show this, and again, it may look kind of intimidating and worrisome, but this is really not cardiac related. Now, the best thing is if you see a lot of these things, always check your patient, right? Don't just assume, oh, it's an artifact, they're fine. Especially if it's looking kind of funky, I would say assess your patient anyway. And sometimes really they may just need a new electrode, or they just need to be replaced back. It may have been loose. I know there are patients though that if they want to get your attention, they may actually try to shake their electrodes, so it makes it look like they're having a dysrhythmia. So just be very careful with that. But again, regardless, I say just assess your patient and check on them. There are patients who need more than just the 5-lead EKG that we have in the telemetry unit. Some patients may need a 12-lead EKG. So some of those patients maybe are patients whom the doctor are suspecting that they're having an MI, or maybe they have some sort of dysrhythmia. But anyway, regardless, the main purpose of the 12-lead EKG is to be able to look at the different parts of the heart. So depending on the lead, on our settings, which lead we're looking at, it's going to be basically telling you something about certain part of the heart. So when it comes to the inferior part of the heart, you have lead 2, 3, and AVF. Now when it comes to the septum of the heart, you have V1 and V2. The anterior portion, on the other hand, would be V3 and V4, and then the lateral wall would be lead 1, AVL, V5, and V6. And then you have the anterior wall and septum, which are often the areas that are infarcted in an MI. You will see that in V1 to V4. So I say please remember that there are some badge, like little badge things that go with your badge that actually have this information. It's always good to know. And I say try to look in your patient's chart to see if they have 12-lead EKG, and based on the abnormality, try to identify where is that located, what part of the heart. When we're measuring the EKGs, we actually need calipers. This allows us to kind of compare and kind of trace and follow and to see any irregularities. And it just makes it easier for us, especially the paper is actually very small. So this just helps us keep track of where we're at and how we're measuring it. But anyway, so these are pictures of calipers. Now we also have the low budget caliper. So this is typically what I use. I used to have calipers, but I haven't had one in like forever. So when I'm measuring EKGs, I basically get a piece of paper and draw lines and then follow along using that paper. So instead of a caliper. So that's the low budget version. Interpreting EKGs can be a little overwhelming and intimidating. That said, while you're learning, it's normal to feel that way. In addition, it just takes time and repetition to really master this skill. And while you're learning, and actually even when you actually learn how to do that, it is very important to follow a systematic approach. So for this specific program, we want you to follow the interpretation step by step. This really makes it a lot easier for you, and it's less confusing rather than not having a method and just not knowing where to start. So there are 8 steps that you have to follow. the first step would be to determine if the rhythm is regular or irregular. So just basically using a caliper, whether the low budget or the real one, and kind of follow along and trace it. Is the rhythm regular? Is the QRS basically happening at around the same intervals? Number two, we have to determine the rate based on the regularity. So depending on how regular or irregular is the rhythm, we use different methods. So if it's regular, you basically do the use the 1500 method, which is getting 1500, which is a constant, divided by the number of small boxes between R to R. Now, if the rhythm is irregular, then you count the number of QRS within a 30 small boxes or 6-second strip, and you multiply it by 10. Now the next step, step number 3, is identifying the P wave. And once you identify that there's a P wave, you have to measure the PRI. Number 4 would be measuring the QRS. Number 5 is measuring the QTI. Number 6, you have to determine if the ST is isoelectric, elevated, or depressed. Number 7 is determining and identifying any abnormal or ectopic beats. And then last, you have to do your full rhythm interpretation. And this is another table that I created just to make it easier on you guys. So on the left side, you have the steps for rhythm interpretation, which we just talked about. And on the right side, you have the normal values. So again, step number 1, you determine if the rhythm is regular or irregular. So normal, what the expectation is, right, on a normal patient, it's going to be regular. Now, next is determining the rate. On a normal patient, it should be 60 to 100. Next is identifying the P wave. If the P wave is present, then we measure the PRI. So the P wave, it needs to be upright and rounded. So it needs to be present, and if it's present, it needs to look a certain way. And then once we identify that, then we measure the PRI, which should be 0.12 to 0.20. Next is measuring the QRS, and the normal QRS for this specific course and program is going to be 0.06 to 0.10. But depending on the reference that you're looking, it may actually say 0.06 to 0.11 or 0.06 to 0.12. But for this class purposes and for the duration of the program, just because of your textbook, let's just follow that the normal QRS is 0.06 to 0.10. Now the QTI, normal QTI should be 0.32 to 0.42, and the ST segment should be isoelectric, so it should be around the same line as your PRI. Now next is to determine any abnormal or ectopic beats. So normally there shouldn't be an ectopic beat. Rhythm interpretation, so basically a normal rhythm interpretation would be a normal sinus rhythm. In addition to measuring, right, regardless of what's showing on the monitor, you have to assess your patient. You have to determine, right, even if it's abnormal, is the patient tolerating the rhythm? And is there any clinical implication of the rhythm? What's going on with the patient? Don't always just look at the monitor. You have to look at what's going on with your patient. All right, we talked about regularity. So when we say regularity, is basically the measurement in between each R to R. So we just want to make sure that there's a same distance from each R to R. So they can either be regular or irregular. So irregular would be, can be regularly irregular or irregularly irregular. So basically, they can be irregular, but their irregularity is quite regular. And then when it comes to irregularly irregular, there's really no pattern. It's like all over the place. Again, we talked about calculating the heart rate. So we have the 6-second strip method and the block rule, which is the 1500 method. So the 6-second strip method would be getting the number of QRS complex multiplied by 10. And this is used for regular and irregular rhythms. Now, the block rule or 1500 method, we basically get the constant, which is 1500 divided by the number of small boxes. And then we basically get the exact rate, and this is only applicable if the rhythm is regular. All right, so this is what I'm talking to you about. So let's say the patient, we're gonna use a 6-second strip, and we're gonna count in a 6-second strip. So there are 30 boxes, in this 6-second strip. And basically what we do, we just count how many QRS complex there are. So here's 1, 2, 3, 4, 5, 6, 7. We get that 7 and multiply it by 10. We have 70. So basically that's 70 beats per minute. Now the 1500 method, or the block method, is basically looking at your QRS and the next QRS complex. We look at basically there are waves, and then we measure the number of boxes between these two. So this example, we basically get 1500 divided by, here there are 22 boxes, that's equal to 68. So there's 68 beats per minute. So we have to always look at the P waves and the P to QRS relationship. So are there P waves? And if they're there, how do they look like, right? Is it, again, it needs to be upright and rounded. And then looking at the P wave, is there QRS, right? Is there a P wave for every QRS, or is the P wave followed by a QRS? All right, so this is how you count for the PRI and the QRS complex. So in measuring the PRI, so this would be the PRI, right? The beginning of the P to the beginning of the QRS. Basically count the small boxes from the beginning of the P to the start of the QRS. And ideally, you want it to be 0.12 to 0.20 seconds. Now, with the QRS complex, we basically measure from the beginning of the Q to the end of the S. And ideally, it should give us 0.06 to 0.10. Now, again, other references, especially in the different hospitals, the normal values there are usually 0.08 to 0.12. But for this specific program and for this course, we're going to follow our textbook. We talk about QTI monitoring. So QTI monitoring is very important, especially when we know that we're giving medications that could prolong QT. So some medications are quinidine, prokinamide, Haldol. Those medications can cause QT prolongation, and some antibiotics actually do that too. So again, be very careful, know the drugs, and that's why it's very important that before you give anything, we don't expect you to memorize everything, but if it's some medication that you are not familiar with, at the very minimum is to look it up, right? We're human. There's only so much that our brain can remember. And so again, if you don't know, look it up. Also with certain patients, they may overdose on some medications. So overdosing can prolong the QTI. Also, if there's a patient that maybe has a new onset of bradycardia, then we want to monitor the QTI. And patients with severe hypokalemia or hypomagnesemia, it can actually cause a QTI prolongation. So why do we care so much about QTI prolongation? Well, we're worried about that actually because it can lead to an R on T phenomenon. So this is when the QTI continues to get prolonged and prolonged, and then basically the R falls on the T, causing lethal arrhythmias such as a ventricular fibrillation or ventricular tachycardia. They said here that this is ventricular fibrillation. Actually, this looks more like a ventricular tachycardia. It's more of a polymorphic ventricular tachycardia. Looks like torsades de pointes for me. So again, torsades, it's so beautiful because it looks like a ribbon, but actually it's not good, right? So this can be deadly for a patient. So this is how it looks like. So again, it looks like VTAC, right? But it's polymorphic. So it has basically different sizes. It looks different. And as you can see here, it goes taller, smaller, taller, smaller, and taller, smaller. So it looks like a ribbon if you're looking at it. U wave. U wave is one of those waveforms that, sometimes they're there, sometimes they're not. So normally, if they're there, they may be small, rounded, and upright, usually less than 2 millimeters tall. Now, it may be abnormal when seen with electrolyte imbalances such as hypokalemia, hypomagnesemia, and hypocalcemia. There are times when the Q wave looks kind of funny. So actually, there is a terminology for that. It's called pathological Q wave. So pathological Q wave is when the Q wave is 1/3 of the QRS, or 1 box wide. So again, if it's wider than 1 box, a minimum of 1 box or more, or at least 1/3 of the QRS. Now, this is commonly seen with patients who have a history of MI. So again, if they come into the hospital and you see this, there's a high likelihood that this patient already had an MI in the past. When we're looking at the ST segment, like I told you guys earlier, we want to determine if it is isoelectric. So again, determining isoelectric is basically compare the ST segment to the PRI, right? So if you draw a line, are they about the same level? So ideally, they need to be around the same level, so that will be isoelectric. Now, when it comes to ST elevation, so it's literal. The ST is elevated. So when you draw a line here where the PRI is, you draw a straight line. You have to look at your ST and it will be higher than that. When it comes to ST depression, the opposite, right? If you draw a line, then the ST would be below that line. So ST elevation is commonly seen in myocardial injury, specifically myocardial infarction, while ST depression is typically from myocardial ischemia, or it may be just reciprocal changes from an MI or digoxin. Now, to consider its significant ST elevation or depression, it needs to be a minimum of 1 box. So if it's less than 1 box, it's not significant enough, so we're not going to call it ST elevation or ST depression. So again, it needs to be a minimum of 1 tiny box. Another thing that we have to determine is if the EKG strip has any abnormal beats. So what do we mean by abnormal beats? So this is basically your normal sinus rhythm. Everything is uniform, everything is happening at the same time. While this right here, it shows a PVC, a premature ventricular contraction, or PVC. So PVC, so you see how this is uniform and this thing happens randomly, right? It doesn't look like the rest of the waveforms and it just happened out of nowhere. So when you're looking at the PVC, you see this thing, it looks wide, bizarre, and it basically is, if you look at this, right, it's a really big waveform. So if you measure it, the QRS is greater than 0.10. So again, it's wide, it's crazy, it's bizarre. And you can tell it's there, it doesn't belong there. Typically with PVCs, there's a compensatory pause. Compensatory pause means that when you see when the next normal beat starts, it's basically about worth of two P to P intervals. So it will be occurring at the time where, in addition to measuring all those waveforms, we also have to keep an eye on abnormal beats. So the first one over here, it's normal. It doesn't have any abnormal beats. As you can see, all these waveforms are uniform. They're basically happening at a regular rate. So everything is quite the same. Now, one abnormal beat that you're probably gonna be encountering would be the PVC. So PVC stands for premature ventricular contraction. So with premature ventricular contraction, as you can see here, this looked the same, and all of a sudden, this weird looking beat happened, right? So PVCs are basically wide, bizarre looking, and they contain compensatory pause. And also, you have to look at this, the QRS, it's going to be wide. It's going to be greater than 0.10. Now, PACs, on the other hand, or premature atrial contraction, they basically, they are early beats initiated by the atrium, and the P waves and PRI may vary. And if you look at this, so these are your normal ones, right? And then this PAC right here, so this part right here, right? If you look at it, it looks kind of abnormal. Sometimes it doesn't have a P wave. It is narrow in comparison to the PVC, right? But if you look at the full rhythm, it just so random, right? It doesn't belong there. In addition to that, typically PACs contain non-compensatory pause, and the P wave may be found in the T wave. That's why you can't see it. So again, the P wave may be absent. So when it comes to compensatory and non-compensatory pause, so basically if the P to P interval surrounding an ectopic beat is equal to two normal P to P intervals, we call that compensatory. Because again, it's compensating, so it's making sure that it's going to happen at basically at the same time as if the PVC didn't happen. Now, the non-compensatory pause happens when the P to P interval surrounding an ectopic beat is less than two normal P to P intervals. So as you can see here, right, this was supposed to be happening here, but it kind of happened earlier. So it doesn't compensate, so it just kind of happens whenever, right? It restarts, so the heart kind of restarts without trying to compensate for whatever they missed out. The last step is basically your rhythm interpretation or identification. So to make it easier on you guys, this is really the format that I want you guys to follow. So first, we're gonna use the pacemaker, the rate, the numeric rate, and then the presence of any abnormal or ectopic beat. So example, so if you have sinus bradycardia, right? So sinus is the pacemaker. Bradycardia is because the rate is less than 60 at 52 beats per minute, right? That's the numeric rate. And then let's say there's an abnormality, then we're going to mention that at the end by saying with, let's say ST elevation with PACs, or if they have multiple abnormalities, we're going to say with ST elevation and PACs and PVCs and so on. Now, another example would be maybe if the result is sinus tach. So let's say the pacemaker is sinus, right? If we have a nice looking, normal looking P wave, has a normal PRI, but maybe the rate is just faster. So again, pacemaker, we always we have to mention the pacemaker, sinus, and then followed by the rate, which is tachycardia, right? And then the numeric rate would be 120 beats per minute with the abnormality, which is ST depression and PVCs. Now, there are instances wherein we don't really follow this completely, especially if it's a normal rhythm. So your normal rhythm would be normal sinus rhythm. So when it's normal sinus rhythm, we basically say normal sinus rhythm at the rate. So, and remember that it stops being normal when there's something abnormal within the EKG. So the minute it has ectopic beats, the minute it has ST elevation, wide QRS, PRI, it stops being normal. So if that's the case, you can just call it sinus rhythm with blah, 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 right? Sinus rhythm at whatever rate with whatever abnormality. Anyway, bottom line, so we have to determine, is it really too fast, too slow? But regardless of what we're looking at the monitor, we have to assess the patient. We have to treat the patient, not the monitor. And we have to basically treat the underlying cause and follow established guidelines. So depending on, what rhythm we're seeing, right, we have to follow certain steps in order to intervene appropriately. All right, so sinus rhythm. So this is basically your normal sinus rhythm. Everything is normal. So sinus rhythm or normal sinus rhythm will have a rate of 60 to 100. The rhythm will be regular. The P wave will be uniform, upright, and 1 for each QRS. And PRI would be 0.12 to 0.20. QRS would be 0.06 to 0.10, and QTI would be 0.32 to 0.42. So this is an example of a normal sinus rhythm. Sinus bradycardia, on the other hand, is an abnormal rhythm, right? And so the rate for sinus bradycardia would be less than 60. Rhythm will be regular. The P wave should be uniform, upright, and there should be 1 for every QRS. The PRI should be 0.12 to 0.20, the QRS is 0.06 to 0.10, and the QTI would be 0.30 to 0.40. That said, the slower the heart rate, the longer the QTI. So you may see prolonged QTI because of sinus bradycardia. Common causes of sinus bradycardia would be beta blockers, antiarrhythmics that actually slow down the heart rate, vasovagal reflex, heart failure, and know that this may be normal for athletes, especially if their cardiovascular conditioning is really good. Some people who are really athletic and fit, their heart rate kind of runs in the 40s and 50s like normally, especially when they're asleep. So again, although this is an abnormal rhythm, this may be normal for certain people. Now, interventions for symptomatic bradycardia. So when we say symptomatic is when they have bradycardia and they're experiencing some symptoms. So maybe example, they have bradycardia and they pass out. That's symptomatic. Bradycardia or they're dizzy. That's symptomatic. Bradycardia and chest pain. That's symptomatic. Basically bradycardia and they have additional symptoms in relation to that. So interventions for symptomatic bradycardia, an acronym that is going to be easy to remember would be APDE, or all people die eventually. Now, A stands for atropine, so it's a medication that we give this patient. Atropine is an anticholinergic, so it will help increase the heart rate, increase the blood pressure. Now, P is for pacemaker, also known as PACE or pacer. So again, this can either be just temporary pacemaker or permanent pacemaker. D stands for dopamine, which is basically a positive chronotrope and inotrope. And then E stands for epinephrine or epi. So epi can increase the heart rate and the blood pressure. All right, so if we have a patient with symptomatic bradycardia, so our interventions, so this looks kind of like your care plan, right? ACT. So we're going to assess, right? What are we going to assess? Circulation, airway, breathing. CAB, we have to assess the vital signs and get a 12-lead EKG. Obviously, depending on the symptoms, that may be more. There may be some labs that we have to analyze with that, but at the very minimum, these are the things that you want to do for this patient. In addition, care, collaborate, comfort it will include establishing an IV access, administering fluids, especially if their blood pressure is down, or maybe if it's related to dehydration, airway if necessary, administering oxygen, and then collaborate. So maybe we have to activate the rapid response team. So this is basically, we're going to talk about it in pretty soon, but this is basically a group of people that will kind of help expedite or basically intervene before a code happens. Now, also administering drugs. We talk about the drugs that we would administer: atropine, dopamine, epi, and then last but not the least, we may need to initiate pacing or prepare to pace. So again, this one doesn't always happen, but usually if all of this are not working, then we may have to pace the patient. So again, it can be external and temporary, or they can actually get a procedure done where they get a permanent pacemaker implanted. Now, teaching when appropriate, obviously, depending on your patient's symptoms, that may not be the priority, but if they're awake, you may want to talk to them about what you're doing, so at least they're aware of what you're doing and they can anticipate, especially when it comes to pacing. So if you're going to be pacing them, that kind of delivers small shock, and so I would say at least give them a warning, educate them about it. This is the adult bradycardia algorithm from the American Heart Association. So this is a 2020 version. I think it should be pretty similar to whatever version is current. So again, we need to assess the patient depending on their condition. So if it's less than 50, basically we follow this along, and depending on what's going on, it's going to ask you, is it persistent? Is it symptomatic, right? It's causing hypotension, altered mental status, signs of shock, and so on. So if it's a no, then we continue to monitor. If it's a yes, then we administer medications. And these are some lists of the medications that we give, and kind of list of common causes of bradycardia or sinus bradycardia. So again, in addition to that, we may need to consult a specialist to kind of help us out with this. Next is sinus tachycardia. So sinus tachycardia is when the rate is basically over 100, so 100 to 150. The rhythm will be regular. The P waves would be uniform upright, 1 for every QRS. The PRI should be 0.12 to 0.20. The QRS is 0.06 to 0.10. The QTI is 0.30 to 0.40. And then just remember that the faster the rate, the QTI actually shortens. So common causes of sinus tachycardia would be fever, dehydration, infection, sepsis, anxiety, adrenergic agonists, so medications, and intense physical activity. So those are not all the potential causes, but those are the common causes. Intervention, so depending on the cause, right? So we have to treat the underlying cause. So if it's dehydration, then we may want to give them enteral and IV hydration. If they have a fever, then we may want to treat that. And obviously, if there's an infection, we may want to give antibiotics. And then anxiety, we give anxiolytics and then help with the breathing techniques. And if it's just, intense physical activity, then they just may need a little break from it. So this is an example of sinus tachycardia. All right, that's it for now. We're going to go over some examples in class. Definitely let me know if you have any